Hello everyone, this is going to be an exam oriented focused on high yield points. So gear up and get focused. Let's go. Upper limb anatomy is huge, but if you learn it system wise, it becomes the most logical and the scoring chapter. So in this video, we'll cover bones, joints, muscles, nerves, arteries, and their respective clinical correlations exactly in the pattern examiners expect. Coming to the section 1, bones. First one, we are starting with the shoulder girdle, which comprises of the clavicle and the scapula. Moving on to the clavicle, it is a S-shaped bone. And then the medial end articulates with the sternoclavicular joint, and the lateral end articulates with the acromioclavicular joint, forming the shoulder joint. The muscle attachments are sternocleidomastoid medially, the middle has the deltoid, and the posterior has trapezius. As you can see in this picture, that this is a clavicle where the medial end is articulating with the manubrium and the lateral end is articulating with the acromion, forming the shoulder joint and forming the joint with the sternum. As I told you about the muscle attachments, you have sternocleidomastoid medially, so this is the medial. You have the sternocleidomastoid, and in the middle you have two, that is lateral and medial. Laterally you have the deltoid, medially you have the pectoralis major, and a posterior muscle group is the trapezius. So this is all you want to know about the muscles. Moving on to the ligaments quickly, you have AC, CC. AC ligament is the acromioclavicular joint, acromioclavicular ligament, and CC is the coracoclavicular ligament. Moving on to the clinical points, it is the most commonly fractured bone. And the middle third fractures, upward pull is by sternocleidomastoid, downward pull is because of the weight of the limb, as the gravity says. Now coming to the scapula. This is the anterior surface because you don't have the spine. This has the spine, so this is the posterior surface. This is how easily you identify the anterior and posterior surface of the scapula when the examiner asks you in the viva or when it is kept for the spotters. So in the posterior surface, you have the spine that is dividing the supraspinous, infraspinous fossae. Coming to the processes, you have acromion process, coracoid process. This is the acromion process. Here you have the coracoid process and you have the scapular spine dividing the supraspinous fossa and infraspinous fossa. Angles and borders are as simple as an inverted triangle. You just have to draw an inverted triangle. What all does it have? It has a superior border, medial border, and a lateral border. And what are the angles you can draw? You can draw a superior angle, you are drawn an inferior angle, and you can draw a lateral angle. What is the importance of the lateral angle? Here you have the glenoid cavity located. What is the importance of the glenoid cavity? There is the attachment for the head of the humerus. So head of the humerus attachment is in the glenoid cavity. And then you have the muscle attachment. The important muscle attachment are rotator cuff. So you know the rotator cuff muscle mnemonic stands for SITS. Supraspinatus, infraspinatus, teres minor, and subscapularis. You have the supraspinatus in the suprafossa, infraspinatus in the infrafossa, and you have the teres minor above, and below teres minor you have the teres major following the latissimus dorsi. And on the medial border you have the rhomboides major and rhomboides minor, and you have elevator scapulae on the top, and the spine consists of just two muscles in the spine. One is trapezius and another one is deltoid. The muscle attachments are as simple as that. Moving on to the clinical significance, you have the winging of scapula. This is the winged scapula, which is because of the long thoracic nerve palsy. So long thoracic nerve palsy is because of that causes the winged scapula. Moving on to the arm, which is also called the brachium, that has only one bone, that's the humerus. Now this humerus connects the radius and the ulnar distally and the shoulder joint proximally. What all the important points you have to remember here? You have a greater tubercle, you have a lesser tubercle, and humeral head. What is the importance of these three? So below the humeral head, this is your anatomical neck, and here below the lesser tubercle, this is your surgical neck. So this is very important for you to remember, and you also have to remember that greater tubercle and lesser tubercle is where you have the rotator cuff muscle attachment. So rotator cuff muscles gets attached in the lesser and the greater tubercle. Now coming to the shaft, you have the deltoid tuberosity in the shaft, and coming to the distal end, you have the trochlea, capitulum, medial epicondyle, lateral epicondyle, and coronoid fossa. If you see the capitulum in the distal end of the humerus, you have to understand that this is the posterior surface of the humerus. Now moving on, this is the olecranon fossa and this is the trochlea. You don't have a capitulum there, but here you have a capitulum, you have a trochlea, you have a coronoid fossa. So this is the posterior surface and this is the anterior surface of the humerus respectively. So this is how, by looking at the distal end, you find if it's the anterior or the posterior surface. Coming to the nerve relations, I told you the surgical neck, that is below the lesser tubercle. Here you have the axillary nerve. In the radial groove, as the name suggests, you have the radial nerve along with profunda brachii. And in the medial epicondyle, you have the ulnar nerve. So these are some of the muscle attachments. You have to know that the deltoid muscle attachment and supraspinatus muscle attachment. As I've told you, all the sits, that's the rotator cuff, gets attached in the greater and lesser tubercle. You have the pectoralis major muscle attachment. And here you have the biceps and triceps muscle attachment. Coming to the clinical points, the mid shaft fracture. So what's going in the mid shaft? Radial groove. So what is the radial groove having? The radial nerve. So what, when the radial nerve is damaged, what happens? Wrist drop. As simple as that. The second one is Walkman's ischemic contracture. So it is because of the fracture of the supracondylar fracture, where you have the brachial artery going. So you can see the squeezing of the brachial artery that is leading to this presentation, that is called Walkman's ischemic contracture. When you look at a patient with this kind of hand, then you have to understand there is a supracondylar fracture. Coming to the next segment, forearm, that is called antebrachium. Antebrachium, you have the radius and you have the ulna. Now the radius, what does it have in the proximal end? It has the head of the humerus that articulates with the capitulum. As you saw, the capitulum in the posterior side of the distal end of the humerus, which is getting attached with the head of the radius to form the elbow joint. And you have the radial tuberosity, introitious border, lateral curvature, ulnar notch, and the styloid process. Now moving on to the ulna, you have the olecranon process, you have the coronoid process, you have the introitious border, and you have the head of the ulna and the styloid process. Now if you see here, you have the trochlear notch here. So you have to understand that trochlear notch is for the attachment of the humerus. The humerus gets attached to the trochlear notch, hence forming the hinge joint. The hinge joint is formed by the attachment of the humerus here. And this is the radial head and this is the radial notch where the radius and the ulna gets attached together. Coming to the clinical points. So first of all, in the radius, we have two clinical points. One is Colles fracture, also called dinner fork deformity. Another one is called garden spade deformity, that is also called as Smith fracture. So these two are the very important clinical points with corresponding to the radius. Moving on to the ulna, you have Monteggia fracture and Galazzi fracture. In Monteggia, as it starts with M, U. So M for Monteggia, U for ulnar fracture. In Galazzi, it's GIR, G, R. G for Galazzi and R for the radius. So here you have the radius fractured and here you have the ulnar fracture, and because Monteggia ends with A is a proximal letter. So the fracture is on the proximal end. Galazzi ends with Z, where Z is a distal letter and the bones are affected distally. So this is a simple mnemonic that you can remember: Monteggia fracture and distal fracture with regard to the ulnar bone. Coming to the last one, hand. Here you have the carpal, metacarpal and phalanges. So So for the carpals, I have a cheesy mnemonic that you can remember, that some lovers try positions that they can't handle. So some: scaphoid, lunate, triquetrum, pisiform. Trapezium, trapezoid, capitate, hamate. So it's 1, 2, 3, 4, 1, 2, 3, 4. You go like this: 1, 2, 3, and 4. Now, coming to the clinical points, you have the scaphoid fracture that leads to the risk of avascular necrosis, because here in the scaphoid you see the radial artery that leads to the risk of avascular necrosis. In lunate dislocation, as you can see the lunate bone, and then you see the median nerve going here. So this median nerve is getting compressed. That is compression of the median nerve leading. That is because of lunate dislocation. Coming to the phalanges, you have the metacarpals. These are the proximal phalanges, intermediate phalanges, and distal phalanges. One important point you have to remember here is thumb has only two phalanges. There is no intermediate phalanges. You have only proximal and distal phalanges. Coming to section 2, joints, the important joints. Number 1 is shoulder joint, which is ball and socket, flexion, extension, abduction, rotation. And stability is because of the rotator cuff muscle, the sits: supraspinatus, infraspinatus, teres minor, and subscapularis. And the viva point is what is the most common dislocation, and it is anterior shoulder dislocation. Moving on to the elbow joint, you have the type of the joint is hinge. Here the type of the joint is ball and socket. Now hinge joint, the ligaments are ulnar collateral and radial collateral. You have the ulnar and radial bones respectively, and ulnar collateral and radial collateral. The common injury is supracondylar fracture, which is brachial artery injury. We have seen before, that leads to Walkman's ischemic contracture. I've shown you the picture also previously. Moving on to the last one, that is the wrist joint. That is the radiocarpal joint. Movement is flexion is more compared to extension. And clinically, you have the Colles fracture, Denophobe deformity. I've also told you about the Smith fracture. These are the very important, that even in your 4th year, or when you go to the orthopedics department for your clinical postings, these questions are going to be asked for you. So keep these in your mind, because these are golden points. Coming to section 3 are muscle groups. So organize the muscle groups in the way examiners love, that is compartment wise: anterior compartment, posterior compartment, anterior flexors, posterior extensors. So your BBC. So BBC always needs a MC. So what is the MC? Musculocutaneous nerve. BBC is biceps, brachialis, coracobrachialis, and these are its function. Coming to posterior, you only have triceps, and the nerve is a radial nerve. So P for posterior, nerve is radial. So when you just pull a line, the posterior becomes the radial nerve. Moving on to the forearm, anterior again flexors, posterior extensors. So in the anterior, you have superficial and deep. In superficial, you have PT, pronator teres, PL, palmaris longus, FCO, flexure carpi ulnaris, flexure carpi radialis, flexure digitorum profundus, flexure digitorum superficialis, and flexure pollicis longus. So these are the superficial and deep muscles, and the main nerve is median, which supplies all of these except flexure carpi ulnaris and flexure digitorum profundus, median half, which is supplied by the ulnar. So you have two bones here. One is median, one is ulnar. In the posterior compartment, again, P for posterior, put a line, it's a radial nerve. And all the extents of wrist and fingers are in the posterior compartment. Coming to the intrinsic hand muscles, 4 important: thenar, hypothenar, interosseous, lumbricals. Median nerve, ulnar nerve, and lumbricals lateral to by median, medial to by ulnar. Very simple. Now, ulnar nerve, what is this pad and dab? So you have to remember that palma interosseous is adduction, and dorsal interosseous is abduction. So that's why you have this P, palmar interosseous adduction, pad; dorsal interosseous abduction, dab. So these are the meaning for these mnemonics, which you have to remember. Even in your classes, your anatomy teachers are gonna say this. And golden viva line is: precision grip is by the median nerve, power grip is by the ulnar nerve. Now, moving on to the section 4, brachial plexus. Students lose a lot of marks here, but keep it in one pattern and this is going to be very easy for you. Branches, cords, divisions, trunks, roots. Now, what are the roots here? You have C5, C6, C7, C8, and T1. Trunks, just 3. Superior, middle, inferior. Divisions, just 2. Anterior, posterior. Cords, just 3. Medial, lateral, posterior. And branches, you have just 5 branches. Now, I want to tell you the high yield injuries in all of these. Number 1, as you see here, this is called Erb's palsy. That's also called as waiter's tip. It's because of C5 and C6. Next, you have, because of C8 and T1, you have something called as Klumpke's palsy. That's also called as claw hand. Then you have the radial nerve injury that leads to wrist drop. We have seen this before in the section of bones. And then you have the median nerve injury that leads to ape thumb deformity. Now, these 4 are high yield injuries that you have to remember in the section of brachial plexus. Now, moving on to the arterial supply. This is the simplest scoring diagram that I can show you. You have the clavicle, right? So, from the clavicle, what is that starting there? It is the subclavian artery. So, clavicle, subclavian artery. Following down, you have the axilla here. So, what does the axilla have? Axillary artery. And then this is the brachium, this is the antebrachium. So, what does the brachium have? It has the brachial artery. And when you come down to the antebrachium, what are the 2 bones? Radial and ulnar. So, radial artery, ulnar artery. As you come to the palms, what does you have? You have the superficial palmar arch and the deep palmar arch, and you have the digits that have the digital arteries. So this is the simplest diagram. You have the clavicle here, so subclavian artery. Then in the lateral border of the first rib you have here, and you have your axilla here, so axillary artery. Then it becomes the brachial artery from the inferior border of the teres major muscle. And as you come down to the elbow, it divides into radial and ulnar. Then it forms the superficial palmar arch, the deep palmar arch, and the digital arteries. So an exam line for you is the profunda brachii accompanies the radial nerve in the radial groove. So as I talked about the grooves and the nerves in the bone section, I told you that along with the radial nerve, you have the profunda brachii also accompanying it. Now this is the exact structure that the examiners expect bones, joints, muscles, nerve vessels, and their clinical coordinations respectively. And if you reproduce this logic in your answers, you can easily score full marks in your upper limb anatomy. And if you found this video useful, and if you want more videos of this kind, comment below, like, hit subscribe, and thank you for watching. This is Amu from Med School signing off. Thank you. Bye bye. Take care.